Yeah. I don't expect that to happen. I think so. But I guess I should make the announcement, just folks, that this is a recorded session. We hope that colleagues will be comfortable with that. If anyone is not comfortable with this session being recorded in their attendance, we invite you to exit the session and then catch the recording afterwards. Thanks very much for that. I appreciate it.
Great. I'm going to start with the introduction. So welcome, and I hope people will keep logging on as I'm welcoming everyone to our very first Lunch and Learn session, sponsored by the Patricia A. Tietjen, MD Teaching Academy. Beth and I, as the Executive Director of the Teaching Academy, are so happy to welcome you all, and especially to welcome Dr. Frank to kick this off for us. The Teaching Academy was recently launched in September. We are a Nuvance-wide undertaking. Our mission is to create a community of educators to celebrate the contributions that educators bring to Nuvance to advance the mission of our clinical educators within Nuvance. We are a 15-person cohort in year one, and we're looking forward already to year two. If that's something that interests you, please reach out, be on the lookout for an internet presence very soon. And you can reach us at teachingacademy@newvancehealth.org. We run a curriculum from September through May. Participating scholars complete an educational project along with a curriculum of course offerings that they do over that 10-month session now. So I think that was it. Okay, great. Now about Dr. Frank. Many of you, and probably most of you on this Lunch and Learn, are attending because you know Dr. Frank. So I think I will keep his introduction as brief as possible, given the many things that we have to say about him. So Dr. Frank is the System Chair of Cancer Research. He oversees cancer clinical trials, and he continues to hold an appointment at Memorial Sloan Kettering. He has served as a medical oncologist for over 25 years. During the course of his career, he has been a much loved and appreciated doctor to many, many patients. Many grateful patients have supported some of his work. He has received a humanitarian award from the Leukemia Lymphoma Society. And one of my favorite things about Dr. Frank is that he is a musician and also an author. And he wrote most recently, Fighting Cancer with Knowledge and Hope. I'm super excited to present him as a friend and a colleague who I have just a ton of respect for. He's going to talk to us about what I think is a really incredible topic in medicine, in oncology, and also in medical education. I think that's the reason that we're all coming together today. He's going to address prognosis, hope, and uncertainty in oncology. So I apologize for the long-winded introduction, but you deserve much more than that, Rich.
Well, the same can be said for you, and so grateful for your friendship and for asking me and Beth. And so I think the Teaching Academy is a wonderful thing. And we spoke about discussing something challenging in oncology, and this is something that comes up every day. I don't know how many people have heard a talk like this. I've certainly never given a talk like this. I don't think I've heard one either. So should be the best one you ever heard if you never heard one before. Okay. This is dedicated to Dr. Tietjen, who I knew from my days at Sloan Kettering, and everybody who knew her knew that they were in the presence of a very special human being and a fantastic physician, and it was a great loss. And only someone like Dr. Skatina could carry on what she started and continued here. So when we think about what doctors do, there are really three ways in which physicians try to understand and control the diseases our patients present to us. One is through diagnosis, try to make sure there's diagnostic certainty. Oftentimes we discuss causative factors. Of course, sometimes diagnosis is a tough issue, and we spend a lot of time trying to make a proper diagnosis in any field of medicine, not just oncology. Causative factors, every patient wants to know why they got sick. Prevalence, how common is their problem in terms of cancer or other illnesses as well? How does it stage out? What's the extent? The treatment options, the mechanism of action of medications, their effectiveness, their side effects, cost of treatment, a number of things that everybody knows well. All these issues we have to discuss with patients. And then there's prognosis, whether it's a muscle strain or a rash or lupus or Alzheimer's or cancer. Of course, people want to know if they'll recover, what's going to happen to them, and in some cases, will they live or die? So, question to everybody: in which categories do doctors spend the most time or the least time? Just think about it. You're welcome to chat in the chat room, kind of working this out. I'll let Beth interrupt me if she wants to, but we have other questions. What's your personal experience? Why do you think this is so? I probably would venture to say that the first two doctors spend the most time on, and the last one is something that sometimes is not even discussed. It's not a life and death situation, but even if it is life and death, it's not the one most spent on, at least initially. So, what is prognosis? Prognosis is at once about the generic and the individual, the typical and the atypical, and the treated and the untreated course of disease. It touches on the difference between knowing and communicating knowledge, between personal and professional domains, and between subjective and objective realities. It's a lot to unpack. I'm not unpacking all of it, but certainly a lot of food for thought. This comes from a really extraordinary book that I will refer to throughout this talk. It's called Death Foretold, Prophecy and Prognosis in Medical Care by Nicholas Christakis, who is a professor, I think, of medicine, oncology, and sociology at Chicago. It's a really special book. Okay, well, I wrote a book, but I'm not plugging it. I'm just saying there are 5 elements of prognosis that I came up with when we discussed these with a patient. We can't always do that, which is part of the reason I tried to give them something to read. When they want to know, what's going to happen to them. A lot depends on the type of the cancer, the grade of the cancer, right? Is it breast cancer? Is it DCIS that's, not spread? It's a low grade. It can be cured with something simple, surgery, or is it a more aggressive cancer? Is it an incurable cancer? Has it spread far and wide? All those issues. And then, of course, all these have to go along with the patient's age and whether or not they're healthy or have other issues that would prevent the recommended treatments. Prognosis in oncology, there are prognostic models that typically are only applicable at diagnosis. For example, if someone has prostate cancer, you can put them into a nomogram and tell them the chances of survival and prostate cancer survival by putting in all their values, the stage of the cancer, the PSA, the Gleason score, and the MSK has a nomogram. Predictive factors, again, there's models and predictive factors for several cancers. But these, of course, don't attach to the individual. They don't apply to every individual. The biological essence of the cancer, I guess, which is unknowable, which means it's going to do what it's going to do and describe all our efforts to describe it. We are not accurate all the time. Okay, so let's just jump into a case. I'll call this patient Anita. She's a 67-year-old therapist whom I treated for rectal cancer 4 years ago. She received chemotherapy and radiation and has been in a complete remission. We did annual surveillance imaging with a chest, abdomen, and pelvis CAT scan. And at the 4th year, a new lung mass was found. We didn't know if this was a metastasis or a new cancer. It was biopsied. It was found to be lung cancer. She did have a history of smoking in the past. She rapidly developed painful bony metastases and was really in agonizing pain. By the time I saw her, she had had the biopsy, and we did the staging workup, and we knew things were serious. And she, battling pain, fear, and overwhelming emotions, she asked me, "What are my chances? Really, don't bullshit me. Why don't I just end it? Tell me why. What's the point of treatment? I'm going to die soon anyway." So oncologists do have to face these questions and try to walk a fine line with our patients to explain it and give them hope at the same time. So speaking of hope and uncertainty, how long do I have is a central question. At the center of prognosis, there can be hope, hope to be cured, hope to live years, hope to live 3 months to the graduation of someone's grandchild or the wedding of someone's daughter. Hope can be many things. Of course, if we're talking about at the beginning of a cancer, most people want to know if they're going to live or die. No hope is kind of no hope to cure it, right? They're going to have to fight it for a while. But there's always hope. And, I didn't mean to say there's not hope, but that means just to beat it. And then there's always the uncertainty, the big question mark that we always have to talk about. That there is uncertainty that has to be lived with. And a lot of our family therapists and counselors here will say that that's the greatest challenge of cancer survivors or people living with cancer, is dealing with not knowing what tomorrow is going to bring. So at that moment in the exam room, my response was to take a deep breath, gather my thoughts and order them for delivery. Pray I would do this right and successfully convey that I was there to help her no matter what, and try to get a feedback of her reactions as I was saying one thing after the next. Was she listening? Did she stop listening? Did she believe what I was saying? Did she trust me? Try to elicit these things with everybody. So here's a question for the group. What do you think Anita's prognosis is with stage 4 non-small cell lung cancer, rapidly progressive now? What should I tell her? Take a vote. I'll give you a few seconds.
Type in your response. A, 6 months, B, 12 months, C, 2 years, D, 3+ years, and E, it's a range, the proverbial bell curve. We're seeing a variety of answers coming in. We've got B, 12 months, C, A or B, C.
Okay, so we sometimes describe advanced cancers that are incurable as a bell curve in terms of survival. There's some individuals who don't respond to the treatment we offer and they die soon. And those that are sort of in the average at the peak of the curve, and then those who have extended survivals, and some living far longer than we could think. It's a small group. They're called extraordinary responders. We all know people like this, and hope for that. And I think everybody hopes for that at the beginning. At any rate, it's what the bell curve. Okay, so back to Dr. Christakis. The physician's charge in prognostication. The ability of physicians to prognosticate is equated with showing restraint, maintaining a sense of perspective and knowing one's limits, acting on predictions to avoid futile treatment, but offering realistic hope based on the latest advances. Requires assiduous data collection, substantial learning, excellent judgment, and considerable courage. It also requires a commitment not to abandon the patient. So that's what we have to do. First steps, I had to arrange to alleviate her pain. Spoke to Josh Marcus. He got her in the next day, operated. She was in agony. At that time, I told her about the advances in treatment would depend on further analysis of her cancer, genomic profiling. Would this reveal a critical mutation, enabling what we call a targeted therapy? Or could she benefit from newer immunotherapy approaches, such as Keytruda? Would we need to resort to standard chemotherapy? I felt I needed to be her advocate and give her realistic hope to reach a place she really could not fathom at that moment, as she was very much in a dark place, as I conveyed. So she was hospitalized, and we'll talk about what happened to Anita. But going through, realistically, what the data shows for someone like her is in 2002, this is a New England Journal article on 4 different types of chemotherapy at the time. Regardless of the type of chemotherapy, the average survival was 10 months. No one really survived years. And there was a major revolution in genomic testing or DNA testing of cancers for specific driver mutations. In lung cancer, the epidermal growth factor mutation was the first one detected. And if you target that with a pill, a tyrosine kinase inhibitor blocks the mutant receptor, it's called a targeted therapy, patients have an average survival of 3 years. And some live several years, more than that, with just a pill. So minimal toxicity often. It's a major breakthrough. It accounts for about 10 to 15% of all lung cancers, much more common in non-smokers. She was not a non-smoker. And we've also entered the immunotherapy era. This is another curve on, this is disease-free survival from the New England Journal in 2016 with Keytruda or pembrolizumab. It targets a molecule called PD-1 on cancer cells. And immune cells, it releases the brakes on the immune system in targeting the cancer. So it basically redirects our immune system to target our cancer. And you can see there's what's called a tail on the curve. Some people keep on living, and there's a very much long-term survival. So right now, among certain patients with lung cancer, there's a 32% 5-year survival. That's extraordinary. And what I was thinking in my mind, why I couldn't tell Anita, it's really bad. It really depends. So ultimately, the test came back. She had lung cancer. It was high grade. Stage we knew was stage 4. She was 70 years old, in pretty good health otherwise. But number 4 came back, and she had PD-L1 levels of 90%. So she was susceptible to the drug Keytruda, pembrolizumab. She didn't have an EGFR or other mutation that we could use with a pill as a first treatment, but she did have a KRAS mutation. It's called G12C. That she does have the possibility of using a new pill called sotorasib for the second-line therapy after, or if she progresses, if the cancer grows on what we choose first. I will plug our research program. We've been on the ground floor of developing this drug and still have a phase 1 trial going on. So thanks to our great research staff. Okay, so in certain situations now, especially in the immunotherapy era, I've really called this the modified bell curve. Some people will have a great response to the immunotherapy or their targeted therapy, and the cancer will be in a prolonged remission. Okay. She had successful spine surgery, stabilization. It was a bit of a long course. She was in pain. She followed up in the cancer center for her first Keytruda, asking again if she should do it. She had consultations with my colleagues in physiatry and palliative care service. I'm happy to report 6 months later, she is completely recovered, has no pain, is back to normal. Her CT confirms this response, and now she asked me, how long do I have now? So that's a great story for now. So therefore, prognosis is tied to therapeutic options. And these are always changing in oncology. I mean, there are new drugs approved every month. It's the most active field in medicine in that regard. It's challenging to keep up. And but we're fortunate that science has created a lot of therapies for most cancers, not all. What about patients with fewer therapeutic options? Let's talk about pancreatic cancer for the moment as an example of a cancer that has not benefited from the genomic or immunotherapy revolutions. Pancreatic cancer still relies on chemotherapy for the most part, except for a minority of patients who may have a defect in a gene called BRCA1 or BRCA2. They do a little better. But we can see 3 typical patients, who come in. We can't tell at the beginning if they're going to be patient 1, have a rapidly downhill course in red, patient 2 in orange, do very well for a while and then rapidly progress, or have a seesaw pattern, do poorly, then respond to the next treatment, and then kind of percolate along, up and down, responding to treatments and surviving longer than expected. That's why sometimes, even though it's a bad diagnosis and a patient may be reluctant to try, we say you don't know, so sometimes it's usually is worth it to at least try. Now, along the way, there are going to be a lot of questions. How long do I have at the beginning? And along the way, how long do I have now? If in the orange curve, for example, at the top, person is going at a year, they think they're doing great, they're going to think they can beat it. But then things drop off fast and it's a shock. In the green curve, a person may think they're dying. How long do I have? Am I dying at the nadir there, and then the inflection point, and then it goes back up, and things are different. How long do I have now? The oncologist, we don't know where, we don't see the curve, so we obviously don't know. And so it's just an example here. I think over a year ago, we just looked at our pancreatic cancer survival for stage 4 cancers. And you can see that although several patients do succumb early in 3 months or 6 months, there's some out 18, 2 months, 24 months or longer, just showing those different curves that I showed. In pancreatic cancer, the average survival for all comers is 11 months. Okay, well, oncologists are frequently asked about prognosis and what's next. Cancer patients ask about prognosis at every visit. You ask one of my partners here, they're shaking their heads between exam rooms because one patient's doing great and you're celebrating, and the next one you have to go tell really bad news, and it's challenging. And we have to answer this question often. And especially we don't know what the next treatment is going to bring. Will it bring a good response? Is it worth doing? Some cancers like breast cancer have 10 different treatments that you could give for advanced disease. And multiple myeloma, lymphomas, others, many others, lung cancer, have now several lines, bladder cancer. There's new treatments all the time. But when is it yet another option best not mentioned or not recommended, as it will do more harm than good, so that no further treatment is recommended? This often comes up in the hospital when hot patients have cancer, they look sick, they are sick, they have advanced cancer, and we're pushed to provide, transition to hospice or, comfort measures. Why pursue treatment? It's not curable. So it all depends on where the patient is in their trajectory. Are they at the end? They've had 5 treatments for stomach cancer, and yes, you're right, it's time. We have to make this hard discussion, or they've just started and we really need to pull them through. But as time goes on, we have strong scientific evidence for only a minority of the decisions we make. So just to kind of get a sense of what we go through, me and my partners and oncologists around the world, there was a 17th century polymath named Blaise Pascal, who tried to apply the rules of logic to come up with a rationale if he should believe in God or not. And so he had many of his theorems became passed on, but one in particular was this matrix, this 2x2 matrix called Pascal's wager. On the left side, he either believes in God or he doesn't believe. And at the top, if God exists or God doesn't exist, what are the consequences? So if he believes in God and God exists, he has infinite gain. He achieves eternal bliss. I guess we're talking about Christianity. As God exists. If God does not exist and he believes, and it's a loss, but it's not a terrible loss. If he doesn't believe in God and God does exist, he's really in trouble. It's infinite loss and eternal damnation. And if God does not exist and he does not believe, he's gained something and peace of mind. His conclusion was, even though probably the smaller chance is that God exists, the risk of not believing is too great, so he's going to believe. So if we apply this to the oncologist wager, or I've changed it to oncologist dilemma, I've adapted this from something called the oncologist wager, which was an article in the Journal of Clinical Oncology a couple of years ago by this Dr. Joseph Jacobson, who's an oncologist, very thoughtful piece. And he discussed adjuvant therapy in cancer, whether to give it to prevent a cancer to come back or not, given the toxicity of some treatments. But I don't think it really applies for advanced cancers, and you're on the third treatment. Should you give it or not give it? So I made this little table. On the left side, if we treat or we don't treat. The cancer is sensitive and we treat, the patient wins, right? They live longer, they have a better quality of life. Because if cancer is causing symptoms and you treat the cancer, the patient feels better. If the cancer is resistant and we treat, the patient suffers. We've caused toxicity and what everyone wants to avoid, which is a bad death from treatment. If we don't treat and the cancer is sensitive, we've lost out. We've lost the ability to extend the patient's life and perhaps improve their life, so there's a lot of suffering. But if we don't treat and the cancer is resistant, that's sort of, the right time to say, pull back and say, don't do anything. And it's time for comfort, and that would be a good death, as we say. So kind of thinking we go through there. So what are the benefits of a prognosis? To alleviate anxiety of uncertainty. Of course, the patient's preferences are important. Some people, what they want to know. The first time they meet you, they say, tell me how it's going, and when we need to stop and I need to, go to hospice, you let me know. Fine. Others, don't tell me. Don't tell me unless I ask you. I don't really want to know. And you deal with family. So there's a lot of nuances, and you have to respect patients' wishes. But you can't let the family tell you not to tell the patient. That doesn't work most of the time. If they're older or infirmed or have dementia, other extenuating situations, obviously it makes the most sense. You don't want to harm the patient in the process. But some people who are not hearing it, you don't want to keep hammering it at them. It's just not the right thing to do. At any rate, a good prognosis or an accurate prognosis allows people to plan their lives, the proverbial get affairs in order, financially plan, avoid unnecessary therapy at the end of life, life review, honoring of wishes at the end of life, and try to plan for a good death, which is one ideally surrounded by loved ones at home without pain or suffering, I guess. What if we don't give a prognosis? Keep the family and the patient in the dark about how much limited time is left. These people are shocked when things start to go badly and everyone starts talking about hospice. There's a lack of awareness to get their affairs in order and spend time with loved ones. They spend their time instead traveling for or receiving toxic therapies that really are experimental treatments that have a very low chance of helping them. Again, there's dismay at the end when it comes. The worst is dying in the hospital or in ICU. This may be the result of the physician not being able to cope with death and have that discussion. But I caution people, other providers who may see the patient subsequent to the oncologist. Patient may claim they know nothing about it. They weren't told things were that bad. Sometimes there's denial. Don't assume the oncologist didn't tell them. You got to speak to the oncologist. I think it's important that we all communicate well. But why might physicians be reluctant to give a prognosis? They're uncomfortable in serving as the role of the prophet, the all-knowing or seeing, having to, foresee the future. We don't want to be held accountable to a bad or a prognosis, fears of making an error. Let's say we say it's a really bad situation and patients live and do well. I mean, that's okay, but you never know what's going to happen. So you could make an error in prognosis, or some doctors don't want to do it because they make them feel like a failure if they do lose a patient, so they don't even want to think about it. Such as some discussions of death are emotionally charged. It's been described as ritualized, somber, anxiety-provoking. Yes, when you have to tell a patient and the family this is the end, it's always hard. There is a lack of training. I think in medical schools, we lack training in this area and nutrition. These are the two big areas we are not taught. I don't know about now, but traditionally. True prognosis can never be known definitively in a specific patient, so there's always that. You can fall back on that, but that's kind of chicken. And I think the oncologist knows the range and needs to convey that. But oncologists cannot always be blamed for the lack of a prognosis. Sometimes we do. Tried to say the cancer is incurable, but many patients will say, I'll be the exception. Or we'll say this is the fourth line of treatment. There's a 20% chance of benefit, may not be worth it. Do you want to stop treatment? And some patients will say, I'll take it. I'll do anything to stay alive. We might say further treatment will do more harm than good. It's best to stop now. Focus on quality of life, comfort, and eventual hospice care. Some individuals may say, I'm not ready. I don't want to give up. Is there anything else you can do? Some may pursue clinical trials. And I can tell you, if you tell a patient who you've treated with everything that you can, and they go to another oncologist, 9 out of 10 times they're going to treat. So it's a bad thing. Everyone wants to be a hero. Challenging situations. Patients who are young, have young children, have family conflicts. Maybe there's estrangement in the family, or it's a broken family, or kids have been estranged, and then they come back and they want to make amends by taking over and advocating for everything. That does happen. Mistrust of the healthcare system. When people have survived far longer than expected, it's hard to finally accept that the last treatment they had is the final one. There's not something else. If they've continued to beat it year after year. And then others have made peace with it and know that they're living so much on, as they say, borrowed time, or much longer than expected, and they do already when the time comes. And certain people have religious beliefs that are against withholding any treatment, and they demand to be treated till the end. Also, a special oncologist-patient bond that's forged over years. We have a mutual and deep affection and admiration between patient and physician. We get to know these people, their families, they get to know us, and it's hard to let go. But we need to do better. Hospice lengths of stays are not long enough. I think the recommended is around 3 months, 90 days. You're allowed to put someone on hospice if they have an estimated 6 months of life or less, but to continue on hospice, the agency needs to demonstrate a continued decline, otherwise they come off. But still, 50% of patients are enrolled for 18 days or less. Obviously, it's not good. How do we improve what we do? I think physicians and all of us have to realize and convey that unfavorable predictions do not mean we have nothing to do and patients nothing to hope for. As we know, patients can have short-term goals or a family event they really hope to get to, and that can be hugely important and a motivator to get people to that time point. Death has to be discussed, that it's going to happen, not just ignored until the end when it's very sudden. So I think engagement of the palliative care service on spiritual teams. Here we have tremendous team support and professionals. Overhaul the Medicare hospice benefit at the end of life. And you say go home on hospice. What if there's, just an elder spouse alone with no kids or family? How are they supposed to care for their husband or wife or loved one at the end of life? There's no hospice 24-hour care, nothing like that. It's a 4-hour home care benefit for like assistance just with basic cleaning, helping with medications, but it's not like hospice provides 24-hour nursing or anything. Expand hospice care outside the home, therefore, as Atul Gawande wrote in Being Mortal, the family structure is broken up. It's not like 100 years ago or 150 in America when people stayed at home, the homestead and the extended families and had family members to help. Today, everyone's scattered to the wind, right? So there's often not a lot of help. Hospitals should be adequately reimbursed for hospice care. I think sometimes a hospital is the right place. And there's a medical aid in dying legislation. Medical aid in dying is requested by some. We're not allowed to do it. It's controversial in the Connecticut legislature. It is something to be discussed. And I guess I appreciate the opportunity to talk. I think I've only scratched the surface. I want to thank Robin Scatina, Beth West, Tietjen Academy, of course, the entire staff of the Whittingham Cancer Center for your incredible, compassionate care of our patients. A special thanks to my good friend, Michelle Daly, who's helped me with all these many conversations with patients. Thank you.
Thank you so much. And I'm so excited we still have time for conversation. So I think probably what's best is, Rich, you can stop sharing. So X out of that box next to leave, but don't leave. And then folks, let's put cameras on if we can. And we're a huge group, but let's try to have some conversation. I'd love to hear comments. I'd like to start with one, actually. Rich, you talked about the reasons why physicians may be uncomfortable giving prognosis and uncomfortable saying when the end of life is. And one thing I find I've experienced at every stage of my training and my career so far is the idea of uncertainty kind of working against me for prognosis. And I think especially in our role as clinical educators, how do we teach our learners to be okay with uncertainty, but still share meaningful and necessary information? So how do you say, I'm your doctor or I'm your care provider, I want to share with you some important information, but there's a good chance I could be wrong on the specifics. How do we do that?
Anyone else want to chime in?
Rich, your camera's still off.
Off?
Yeah, I don't know if you can turn your camera on.
All right.
But yeah, I'd love to hear from others about that thought or other thoughts.
Perfect. We see you now.
Okay. I'd be happy to hear from others. People have heard me. Michelle, anybody? All right. Well, can you hear me?
Yes, we can hear you.
I think people appreciate honesty and they appreciate uncertainty. They know we don't know sometimes exactly. It depends on the situation. You have a different set of diseases that you deal with, but different issues. Sometimes it's clearer in the ICU, or maybe chronic respiratory diseases. It's a different mindset. But again, yeah, it's all over. It's where are they in the illness trajectory is one thing, in terms of how certain you're going to be. How many therapies are there that are out there that they could still avail themselves of? What are the chances that those strings will really help them? Also, how much they want to go, they're willing to put up with. What do they want to? How do they see things? You know, I had a patient who was a really suave, great guy. He was a real man of the world, and you know, he was going through treatment, and he was entering a phase where he wasn't looking the same, and he had lymph nodes, and I said, you know, we got to ramp up the treatment, and he was like, am I ever going to get back to being, you know, Jim, like the man? And I said no, and he said, I'm done. You know, I don't want this. I don't want to see myself going down in a weakened condition, and that's it for some people. I don't know if that was addressing your question.
Yeah, I think I think one of the things that's come with a little bit of maturity is settling into that discomfort of not knowing everything, but still kind of doing my job as the doctor and still sitting there and having that conversation. And if I don't have all the information I'd like to have and that I know my patient would like to have.
Folks, are there other questions? Feel free, you can just unmute and ask, or if you're able to use the raise hand feature, you can also do that, but we're a quiet enough group to jump in.
Yeah, let's hear it.
Questions, comments for Dr. Frank?
Come on. This crowd, come on, something's wrong.
I'll make a comment. Can you hear me?
Michelle.
Yes, Michelle.
Michelle Daly. Thanks, Dr. Frank, for the shout out. And I really appreciate all the conversations we've had for 20 some years working together with patients. And one thing that I think is challenging as a supportive clinician is working with the families. And although they know on some level that, you know, the patient will eventually die, it does seem to come as such a huge shock when that downhill spiral starts. And one of the things that's been really helpful for me over the years is reflecting with the patients in their bereavement, who will tell me, you know, I knew it was going to happen, but I just couldn't think about it. I didn't think it would actually ever happen. So there's this dichotomy, I believe, in the way that people think about a prognosis and death, that both of those ways of thinking can be right. You know, the person grieving the loss will say, I couldn't face that it would actually happen, because that would have meant that each time I was talking to my loved one, I would be crying and a wreck and not be able to talk. Whereas you speak to the patient and they'll say, I don't really want to bring it up with my wife because I'm afraid, I might upset her. So I think back to your point, Dr. Frank, being transparent and open after developing a trusting relationship with the patient and family is so key, so that we can minimize the chance of there being just such a shock at the end. It's really all about their relationship, and that's where I hope the supportive team, you know, can help the doctors, because you doctors have limited time with your patients. So please call upon palliative care, myself, our social worker, our spiritual care providers who may have a little bit more time, so that we can help with those discussions. So really just honesty and transparency. And deeply, deeply respecting the beliefs and emotions of the patient and family, even though we may be saying in our own heads, you know, don't you get it? This is really happening. We must be with them where they're at, so to speak.
Thank you for those comments. Any other comments, questions? Don't be shy. Well, I'll just share, I guess, in the meanwhile, and to follow up with Michelle's comments about customs and belief systems and wishes, and we've been doing a lot of intercultural development work with our teaching academy members, and I can't think of a subject that's more laden with deeply held values and value systems than the issue of death or transition. And so you know, every culture has different perspectives and different beliefs regarding death. And so I wonder, you know, if this is, and this, I'm a non-clinical person, full disclosure, just what sort of support is available to physicians and, you know, clinicians in learning about maybe cultural general frameworks to sort of have at least an idea of the types of questions to perhaps ask diverse populations, or sort of starting points for future conversation around these difficult questions and difficult issues. And, you know, perhaps that could be something where we seek, you know, and to offer more education in this area in terms of supporting cultural learning related to death and difficult issues.
Yeah. I mean, this whole this is a huge movement, obviously, for health equity and diverse representation in medicine. I think it also helps to have it in every aspect of the care we provide too. So diversity of providers, whether it's spiritual providers or palliative care, physicians, you know, I think you're right. There's a trust issue, and it's important for people to be able to, over time, they do, I think trust is usually built, or the patient will leave you. But, you know, some things maybe, you know, it helps to connect culturally, right? And ethnically, and the more diversity you have, the better the team can connect in some ways. Because there are groups of people that, right, don't trust as much.
Mm-hmm.
Yeah.
Most patients and their families actually, in my experience, really appreciate when you ask them, you know, tell me about how your family and your culture, if it's different from one's own, or if it's a different race, you know, how do you and your family, what are the rituals and the beliefs around death? How do you support each other? As you referenced in your talk, there are some families in which culturally the person who's ill is not to be told. So I'm not saying that we endorse that as an institution, but we need to respect and understand how that has come about culturally and to enlist the support of the family. So I think asking the patient and family is really important. You know, never go into it acting like you know when you don't know, and just sort of saying, I don't know. I've had patients who maybe have been upset say something like, you know, you have no idea what it's like. And I'll say, you're absolutely right. Please help me understand the culture, the differences, and how we can better understand how best to serve you. So just asking, in the absence of formal education, ask the patient and family.
Nice.
But we have time for one or two more questions or comments. don't feel like you can't speak up. We're a large group, but there's time.
I see a question in the chat box. I'll go ahead and read. The question is, do you have any suggestions for the scenario in which the patient is ready to stop treatment, but the family is not, and guilts the patient into more treatment? Thank you for that question.
Yeah, I mean, you're serving the patient. Okay, so family has to understand that's it, and you have the bond and the relationship with the patient. It's their life, and they just have to accept it. And I think there are ways to talk to them, and they can see that you are advocating for the patient. The patient is rational. They know what they're saying. They're able to say that they've lived life up until this point. Whatever their words are, if they can express it, I think, to their family in your presence to get it out there, so everybody hears. This is often what we do. We get a family meeting, right? Because this is a difficult situation of everyone in the room, Michelle and Elam and the family. And so it's out there so everybody can hear. This is what the patient wants. That's it. Anything, right? Michelle, Mary, anybody?
It all gets back to better understanding where the family's coming from. So often the push of the family member to have treatment carry on is it's their belief that that's synonymous with life and not necessarily quality of life. So very often the family meeting really teases that out, and each person gets to express their emotions in the open room versus, in sidebar conversations. So most of that, the push by family is rooted in fear and deep sadness over losing this person they care about. So just better understanding that and giving everyone a chance to speak their mind is helpful.
Right. Yeah. I think, like you always said, the reasons for understanding, why the family feels that way, or which family members feel that way, or what do they think treatment's going to result in. So maybe if you can address those things and say, look, it's not really going to cure them. They're not going to get much benefit. It's better I always try to say, whatever weeks or months are left, better you spend it doing everything you want to, especially if you're functionally capable now, not so handicapped or sick that you can't do anything. That's not the time to stop treatment. You want to stop it before. And you can do some things that you want to do. But you have to have that tough conversation in time. Yeah. So again, getting the family to know that the reality of the situation, I think, is important.
Rich, I have a question for you. How do you dispense hope as an oncologist? Like, it's one of your most powerful tools, but it has to be used wisely. Can you kind of reflect on that for the group?
Like I said at the beginning, this patient that I presented, I didn't know what her profile would be in terms of what the cancer would be susceptible to. I kind of had to say, I know this is really bad. If we don't do anything, you'll be dead in weeks. We have to try to make you feel better right now. And let's see what the results could bring. It could be good results that you could potentially really have, all these sort of qualifying words, because I'm in a land of uncertainty at the beginning. But then later on, if someone's had treatment and it's just not going well, in the hospital or something, I'm not going there to, give them hope. I would say I want them to have more peace of mind. Yeah, I'm happy with that. That they at least know that we've tried. I'm recommending nothing more, and that they're okay with that. Whether they hope for this something, you hope But oftentimes that does sometimes lead to peace because they've stopped trying. And that can be hopeful. Well, I just want to say I don't do this well all the time by a long shot. And, I was telling something about, practicing medicine or oncology. It's like every day you think of more of the things that you didn't do right, which makes us humble, right? I mean, if you're at a job and you're a superstar and everything's great, you can't really ever see yourself and your weaknesses. But, try our best, always learning from our colleagues. Some of my colleagues do this extremely well, and I'm glad to be around them.
Sounds like a nice way to end it. Thank you so very much. We were lucky to score a rock star for our first session. And all of your adoring fans, I think, made it really incredible. So thank you to the large group who joined. Please be on the lookout for monthly offerings, monthly lunch and learns. Let's see. Beth wants me to plug something else. We have office hours, one day a month. Please reach out. Thank you so much to those who included emails in the chat. We'll send out the video by email. If you'd like to learn more about the Academy, connect with us at your location. Just respond to that email. And we look forward to learning about what you do and hopefully engaging more. Dr. Frank, thank you so very much. This was wonderful.
Thank you for.
Bye.